Okay, on to the next. We're going to have a little video, The Meaning of Empathy. To help me introduce our next speaker, Dr. Esther Tailfeathers, please watch this short trailer from the documentary, The Meaning of Empathy. In part narrated by Dr. Esther, we encourage you to watch the full documentary when you get home. I watched part of it the other night, and it is amazing, so I really strongly recommend you all watch it when you get home.
This is home, Ghana, otherwise known as Kainai, or the Blood Reserve. Nestled in the foothills of the Rocky Mountains, Kainai is the largest reserve in Canada. Beginning in 2014, fentanyl flooded the illicit drug trade on the reserve. This new reality has forced our community to approach addiction in radically different ways.
The difficulty was in convincing people that harm reduction is the route that we have to take.
By no means is it celebrating addiction, but what it does is it celebrates the lives of people without judgment.
Our group here is looking at expanding what we have to do to help our community heal.
There you go. It could save a life.
It's very heart-wrenching when you go on a call and people are breathless.
And we can't sit back and expect things to change without doing the work.
Progress notes. Trying to get off these oxyators by yourself, it's hard.
The next thing we want to do is address a detox facility on reserve.
History marks the Bloods as some of the fiercest, strongest people there ever was. And I want us to get to that point again.
I'm happy.
We have a Blackfoot word that's called Gimmapi Bitsin, which means giving kindness to each other.
Thank you.
And that means also compassion for those who are suffering.
It's an amazing thing that they've done. And in my eyes, they're heroes.
This is the Opioid Crisis and Recovery Program. Esther Tailfeathers is a medical doctor who has done extensive work in the area of opioids and drug use and been involved in the creation of recovery programs. She will share her story of this significant problem and the strategies involved in caring for those in need of recovery programs. Dr. Esther Tailfeathers is the medical lead for the Population, Public and Indigenous Health Strategic Clinical Network at Alberta Health Services. She received her medical degree from the University of North Dakota and has since served communities such as the Blackfeet Community Hospital in Montana, the Blood Reserve, the Cardston Hospital, an emergency room, and in the remote northernmost community of Fort Chipewyan, not sure I pronounced that correctly, sorry. Dr. Tailfeathers was born and raised on the Blood Reserve, Kainai First Nation, located in southern Alberta, and has lived in many Indigenous communities, including the Northern Sami community in northern Norway. In recent years, Dr. Tailfeathers has focused on the Blood Tribe's response to the opioid crisis. She will speak to us about her experience and this crisis, including harm reduction and treatment and addressing the upstream detriments of health. Dr. Tailfeathers is currently the Senior Medical Director, Provincial Indigenous Wellness Corps at Alberta Health Services. Please welcome Dr. Esther Tailfeathers.
Thank you, Trish, for that introduction. Thank you, everybody, for the invite.
And thank you, Laura Lee, for a very beautiful presentation. I'm going to just get into it. I just want to thank you for the opportunity to educate. And I think the more we know about the situation, the more we understand what we need to do together and where we can go. So I'm going to talk a little bit about what's happened to our community, Blood Reserve, which is about 13,000 members, but many you see here in the city of Lethbridge and the city of Calgary. So I think that the issue I'm going to talk about is a global issue, even though we suffer on the Blood Reserve, and here in the city of Lethbridge, many of the people that you see downtown are my people. And so this is a global issue, and as much work as we've done to try to address the opioid crisis, we recognize that we're part of a huge picture, and it's not just Blood Reserve. It's not just Alberta, it's not just Canada, it's North America and the world. So I want you to keep in mind, and I really thank you, because I know there's a lot of thinkers in this room. I really thank you. Thank you, Pat. Yeah, put it. Thanks, Pat. Think about policy, and policy is where we need to go in terms of how we deal with this crisis that just won't go away. So the drug crisis continues to cripple our communities. I never thought it would get to the point that it is now, but I'm going to do a little bit of educating, and then I'll see the wheels turning. So this is a little wheel that I created about the continuum of care of addictions, and I'm not sure if I can get the pointer on this, but anyway, the continuum of care of addictions, if you can see, it's very, very small print. But at 12 o'clock, where things start, is prevention. So you're going from 12 o'clock at the beginning of the clock, or the top of the clock, and then you see the first thing that we should do is prevention in the continuum of care. And then the second part of that, it's around 2 o'clock, is the first response or harm reduction. And so we need to save lives, and the first thing that we did at Blood Reserve was to figure out how do we save these people that are dying from fentanyl overdoses. And the second part, the second quarter of the pie or the clock is outpatient clinics and acute care. So working in Alberta Health Services, I've been able to see where we need to address what we do within the medical system. And then the third part of the pie or the clock from 6 o'clock to 9 o'clock is detox, treatment, and aftercare. And I'll be talking about this within my... Oh, thank you. Thank you, thank you. So hopefully I can figure it out. Okay, so you can see at the bottom here, or this area here, we have detox, which is not available on reserve for jurisdictional reasons, but we were able to break those barriers and start a detox. And I'll talk a little bit about that. Treatment and what that means, aftercare and how important that is. Supportive housing, and I'm speaking to the right crowd here because the Raymond Rotary Club has helped us with a project in Moses Lake with supportive housing. And then finally, the community supports and social determinants. So yesterday, I think you had Travis and Tony here, and they were talking about housing. But that's also a global issue, something we have to discuss. I know I spoke to a member from Fort McLeod here, and they've been really addressing the housing issue in Fort McLeod. So I think that we're all on the right page in terms of what we really need to be doing. Okay, so a little bit about what happened when this started. It all began for me in 2014, and as you heard, I work in the emergency room in Cardston. But I was actually here in Lethbridge in the Walmart parking lot, just coming into town to get supplies for the Sundance. So I was dressed in my oddly mismatched clothing for Sundance because it was morning, and I had a skirt on, old running shoes, and a hoodie. and just picking up groceries and supplies at the Sundance. So I pulled into the parking lot, and I pulled up next to a gray-colored van, and I turned my engine off. And as I turned my engine off, I could hear children screaming in the van next to me. So I looked over, there were 3 children screaming in the back of the van, and then I looked, and the driver, or the person in the driver's seat, was slumped over, and he was slowly slumping over. The door was ajar, and he fell between the door and the pavement. And so, of course, I jumped out of the van and went to check him, and he wasn't breathing. Checked for a pulse, there was no pulse. And so subsequently pulled him out of the van, laid him on the pavement, and started CPR and called to the crowd, can you call 911? We have somebody who's unresponsive. So they called the ambulance. I started CPR. I was able to get a heartbeat. And then he wasn't quite breathing on his own, but continued CPR, had a few breaths from him, and then the ambulance arrived. This was a young man in his 20s. His children were all very young. And he looked healthy. His body looked healthy. But his pupils were pinpoint. And I said to the ambulance attendant when he arrived, this is a young man. I think it's an overdose because he doesn't have any signs of a cardiac event or anything else, and his pupils are pinpoint. And she looked at me in my oddly colored clothing and rolled her eyes and thought, what the hell, who's this person telling me what's going on here? So I didn't tell her I was a doctor. Yeah. So anyway, they did take him off, and that was the first fentanyl overdose that I had seen in community, and we started to see more and more. I work with a good group of doctors in Cardston. We usually see maybe 2 to 3 overdoses in a week. We were starting to see 2 to 3 overdoses in a day. And fentanyl was not added to our toxicology screen. So we're looking at all the other toxicology or the tox screen, and it wasn't on there, but we had heard that there was fentanyl in the province. So we added fentanyl to the toxicology screen, and lo and behold, almost all of the overdoses that were coming in greater numbers had fentanyl in them. And we began to see deaths due to overdose. And so we knew that was something was up, and we needed to respond. So in December 2014, I wrote a letter to Chief and Council and said, we have an impending crisis. We really need to alert our community and start to do some work on this. So they issued a community alert. They recognized that it was fentanyl, and we started to try to figure out where this was coming from. So we drew the police into this. So the Blood Tribe Police were involved in this response, as well as the RCMP. So the community began to meet. We had evening meetings and meetings, discussions on what do we do about this, where do we start. So in January 2015, we assembled a core team, and much like what you do as a Rotary Club, you bring community together and start discussing what really needs to be done. So I'm in the right crowd in terms of recognizing what needs to be done for a community response. So we brought together addictions workers, social workers, health workers, teachers, family members, people, everybody from the community. And Laura Lee is right about food bringing people together. So there always had to be food at the event, and that usually brought more people in because they felt comfortable coming in. Sharing a meal is always a good thing for humanity. So the Blood Tribe Police Service launched a crime reduction unit. We were trying to raise money for a drug sniffing dog, but they're like $70,000, so at that time we couldn't afford that. There was a series of awareness walks that took place in various parts of the community. So we have 3 smaller communities or villages within the reserve. One is Moses Lake, which you see as you come into Cardston. One is Standoff, the town site, and one is Laverne, which is very close to the village of Glenwood. So our children actually took to the villages and took signs and took them through. So one of the things that we started to do was look at data. And so we did some raw data here. And this slide, you'll see me teaching chief and council when the film was being made. And what we did is we took a look at using the overdose stats from the Blood Tribe EMS. And from June 2014 to November 2016, we started to graph the overdoses and when they were taking place. And so we graphed it, and as you can see, there's a steady incline from the beginning till the end of this graph, but you can see lots of spikes. And so what we were starting to identify is that when there was money in the community, such as AISH, social services, and money came out, we had spikes in overdoses. So people were using their money at that time to purchase or to buy drugs. The drug dealers were coming into our communities when they knew when the money was there. And there's one large spike. There were 25 overdoses in one day. And that was during our celebration, our Indian Days celebration. There was a tribal distribution of about $200 per tribal member before that day. So the drug dealers knew exactly where to go and where to get their money, and we saw 25 overdoses. So we know that it's linked to money in the community and how that is spent. This is just another showing of the graph where there's a steady incline, and it's much higher than that now, but I haven't been doing the data and stats for a while. Okay, so this is a new graph that's come up from AFNIGC, which is Alberta First Nations Indigenous Governance group on data. And this is a mortality data on the accidental opioid deaths in Alberta. So there's two lines. You can see the blue line on the bottom, which is the non-Indigenous or non-First Nations overdoses between the period of 2016 and 2020 and the deaths associated with that. So you can see that it's pretty steady with the blue line, the non-Indigenous line. But look at the First Nations line. You can see the green line slowly rising until 2019, and there's a steady increase. It almost spikes up straight. So we began to lose a lot of people in 2019. So that was before COVID, but it also was a time when there was a change in provincial policy. And that policy was closing the safe consumption sites or not opening the safe consumption sites. It also was a reduction or limitation in harm reduction services across the province. So it did impact Indigenous people across the province, and we saw higher mortality rates because the policy had changed in the province. I would say that there's probably a similar picture across the country in terms of mortality rates. And soon after that, of course, COVID hit and didn't help at all because the isolation in COVID allowed for people to overdose in their basements, in back alleys, and where they were alone. So the isolation of COVID actually increased the death rate because people were dying alone. Okay, so I have a little bit of data on the confirmed drug and alcohol poisoning deaths all the way from 2016 to 2020. So the first one here, I might make you dizzy with this, with a pointer, but the first one here is alcohol. So you see alcohol is one of the ones, and the colors are just the years, 2016 to 2020. So our first culprit, and we've always known that in the Indigenous population, is alcohol. The second is codeine, and it's gone down, and I'll show you why. Benzodiazepines, which is Ativan, any of the ones that end in PAM, and then you'll see fentanyl. Fentanyl is the highest of all the ones that are causing the poisoning deaths. Carfentanil, which is much stronger than fentanyl, is not such a huge culprit. Then we see methamphetamines. So we see methamphetamines here. Hydromorphone, which is prescribed. Oxycodone, which is prescribed. Cocaine has basically a steady rate. We don't see a rise in cocaine. And then heroin, we're actually seeing a decrease in heroin through the years, although we probably need to continue to watch that. So our 4 big culprits are alcohol, fentanyl, methamphetamines, and those are the 3 big culprits. And so what we're seeing is a mixed picture of opioid use disorder, or people that are addicted to opioids, which is the fentanyl. And then we're seeing an ever-rising increase in methamphetamines. So if any of you know the street lingo, or the people that I work with, they'll tell you they take down and they follow it with side. So down is a word that's used for fentanyl and heroin, and at one time was only snorted, and then it went to smoking, and now it's injected. So that's why you're seeing the needles, across the city and the cities that you come from. And then it's become a real mixed picture as well, because down is followed by side, which is methamphetamine, and the methamphetamine is what does a lot of neurological damage over time. So if you're seeing people with unusual neurological movements, it's because of the methamphetamines that are mixed with or taken right after the fentanyl. So this is part of the story here. This slide shows you that the opioid dispensations. So our medical professionals, including myself, are part of the opioid dispensation rate. And if you take a look at this slide, the blue to your left is the non-Indigenous male and female prescription rates to non-Indigenous males and females, and that includes Tylenol 3s and Percocet, oxycodone, all of the prescribed opiates. And if you look to your right, the dark pink and the light pink are First Nations females and males. These are prescribing practices of my colleagues. And so over time, what we see is a 2 times higher prescribing rate or dispensation rate of prescribed opiates for non-Indigenous males and females. So we know that was part of the beginning of this problem, is the overprescribing of opioids to Indigenous people across the country. First Nation stats from Alberta, from the AFNIGC, we know that, and this needs to be updated, but the rate of opioid toxicity death is 3 times higher, but currently 7 times. So I should have updated this. It's 7 times higher than the normal population. The rate of emergency department visits related to opioids and substances of misuse is 6 times higher. The rate of hospitalizations, 5 times higher. The rate of EMS responses to this is 7 times higher. And the rate of opioid dispensation from community pharmacies is 2 times higher. But because of the work of the College of Physicians and Surgeons trying to reduce the rate of opioid prescriptions to all people in Alberta, we see this on the decline. So the prescribing rates are actually going down. And that's why when I showed you the other slide with the legal or the prescribed opiates, they're actually going down. At one time, they were much higher. So this is I keep this magazine with me all the time at home. It's an Ixini, and it's our community communication magazine. And so it shows a picture of our people all coming together, meeting, because that's what we had to do. That's what we had to do, is come to some understanding of what this problem was and how we were going to address it as a community. So as I said, the kids, they put together, these are some of the posters that the kids put together. A number of the teachers helped put the posters together. And they walked through each of the communities, our small communities, and told the communities they were tired of the drugs. They were tired of the deaths. A lot of them had lost their parents, and they wanted this to end. So with some of the work that we did, including the introduction of naloxone, and naloxone was only used by doctors. I mean, I knew naloxone well because we use it in the emergency room to reverse an overdose. It wasn't used anywhere else in Alberta in the hands of lay people except in Edmonton, where the, now it's called it's not Streets Alive. Marlis Taylor, the nurse that was part of that, started that. So the only people in Alberta that had use of naloxone were the people in downtown Edmonton. Other than that, nobody else, actually no other First Nation in Canada was using naloxone to save lives, and that's a huge part of harm reduction, is saving lives. So we had this discussion on reserve, and a lot of our people were saying, well, isn't that just enabling the drug users to continue to use drugs? And our reply to that was, you cannot enable a dead body to continue to use drugs. And so many of our elders who were initially against harm reduction realized that they could have saved their loved one's life if they had naloxone in their hands. So we did a huge blitz in our community. It's called Train the Trainer. And we went and got a number of our people trained to train others to, and we had a lot of fun with actually doing the Train the Trainer and training in the community. So people participated. Some people played the victim. Some people played the savior, and learned how to use naloxone. The guy from ISC, or Indigenous Services Canada, Hakik Virani, who's a very well-known addiction specialist in Alberta, worked with FNIB and got us our first 50 kits of naloxone, and those were all put into plastic lunch boxes and they were very primitive, but we got the naloxone out to the community. That guy was fired by the federal government for providing the naloxone to the community. And when they realized that there was no policy across the country regarding naloxone on First Nations or in the hands of lay people, the chief wrote a letter and he got his job back. And as a result, we see naloxone all across the province and in many of our First Nations across the country, because this is a really positive step in saving lives, and we really need to look at saving lives. We have so many orphans on our reserve. We have so many people that we've lost. So because of our actions, the last 2 deaths occurred on reserve on March 20th, 2015. And so for 3 months, we had 0 deaths. So we know that we did something right, and harm reduction was a first step along on that continuum of care that was really important. Education is probably one of the most valuable tools in terms of this continuum of care and saving lives. We established an emergency hotline, and then the children of the Blood Reserve, they took an active part in doing the protests and letting adults know that this is something they wanted to end. And so they're going to do it. They're going to do another round of this in about a month. So we have the Blood Tribe police here, Jim Bennett, who has been very instrumental and has been with our Blood Tribe department not the EMS, but our police service, who also is part of the Raymond group, who organized getting cabins for the homeless and addicted in Moses Lake. So they built 5 cabins in Raymond and provided them to the reserve to help house people that were on the streets. So, yeah, thank you. Yeah, so there you go. The Rotary Club was helpful in that, and they also provided mattresses and the furnishings for these units. Okay, the underlying reasons for this crisis. I know we have only a few minutes left here, so I'm going to try to get through this. So why is this happening? Why is this happening to Indigenous people across the country? Why are we seeing, those, the differences in the graphs? Shouldn't it be the same between the Indigenous and non-Indigenous people? Shouldn't we see the death rate the same amongst both Indigenous and non-Indigenous? Why is it different? Okay, so the 3 things that I have come up with is, number 1, historic trauma, residential schools, and the adverse childhood events, and I'll go into that a little further. So, yeah, I'm hurrying. Social determinants, sorry about that. Social determinants, poverty, employment, and housing. Health service delivery, Indian health policy in the past, and primary care and prescription drug prescribing. So starting in the 1880s and lasting until 1996, children were taken from their homes and put in residential schools. It was illegal to keep your child at home, and they were as young as 4 and 5 years old that were taken from their homes and put into residential schools. Many of the children are physically or sexually abused, 5-year-olds, 6-year-olds, and you will hear much of it or have heard much of it in the Truth and Reconciliation talks. But what does this do to children? You know, they can't just get over it. So the 3 types of ACEs, adverse childhood events, include abuse, which is physical abuse, emotional abuse, and sexual abuse. The second is neglect, physical neglect and emotional neglect. The third is household dysfunction, so mental illness, an incarcerated relative, a mother that's treated violently, and substance abuse, and divorce or separation. Those are the ACEs, the adverse childhood events, and they have a huge impact on childhood development and how we live as adults and how our health is determined by what's happened to us as children. So what impact do ACEs have? In our behavior, lack of physical activity, smoking, alcoholism, drug use, and missed work. Believe it or not, missed work is part of that as well. Physical and mental health, severe obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, COPD, and broken bones. So the impact is quite high on the health of Indigenous people across Turtle Island, and those that were themselves incarcerated in residential schools, or their family members were also, or the intergenerational, or the handing down of that trauma from generation to generation has resulted in what we're seeing in the health impacts of Indigenous people across the country. So the health effects of intergenerational trauma include increased suicide attempts and poor mental health status, a decline in social cohesion. So you're seeing age groups that are not communicating with each other. We have kids that are totally on their devices, or kids that are totally left without parental activity, like family activity. And we see that as a big part of what's happening to our young people today. It affects parenting styles and attachment styles. It increases addictions. And children may experience greater abuse, neglect, and household dysfunction, which increases depressive symptoms. Okay, so on the other side of it, why am I here when I'm part of intergenerational trauma? Why are there a number of successful Indigenous people? Why are there people who have basically normal lives or not so dysfunctional lives? And that's because of the positive childhood experiences. Why are you here? Because you probably have a lot of positive childhood experiences in your past that overcompensate for the negative or the adverse childhood events. So 7 of the positive childhood experiences that we can talk about and probably support, if we're actually trying to support communities, is children who are able to talk about feelings with family without fear of shame or any repercussions. So children should be able to say, I feel angry, I feel sad, and be able to say that without feeling that they need to be hushed. Feeling supported by family in difficult times, participating in community traditions, whether that be your religious traditions, your family traditions, or community traditions, cultural traditions. Feeling as though one belongs in school. And so having people at school that welcome children there and make them feel comfortable, and addressing issues that maybe make them feel like they don't belong there. Feeling supported by family and friends, and at least 2 non-parent adults who truly care. And so that's, uncles, aunts, a teacher, or somebody in the community who really shows that they care, and feeling safe and protected by adults at home. So income being a powerful determinant, I'm just going to say that there has been a number of studies done, and this is probably the most powerful social determinant. And there was a study that was done by Lemstra and Neudorf in Saskatchewan showing the disparity of health as it relates to income status. So that is the biggest modifiable risk factor in the disparity of health status, both in all populations, not just in the Indigenous population. So I'm just going to skip to what it was at one time and what it is now. Neonatal abstinence syndrome is a syndrome where children are born into addiction. So the mother is addicted and the child and delivers the child at hospital. So if the mother is taking morphine or the mother is on fentanyl, the baby is born addicted to fentanyl. And so they need to go through a withdrawal from the fentanyl in the hospital. So we see our pediatricians in our hospitals here in the NICU areas dealing with neonatal abstinence syndrome, where a child needs to be withdrawn from the opioid that he or she is born to. And so that means tapering them with small doses of morphine until they're through their withdrawal. So what I did was I worked with the community health people, and we did stats on actually just on the 2 years from 2014 to 2017, 3 years. And we took a look at the number of babies that were born into neonatal abstinence syndrome. So the first year that we started seeing this problem, there were 23 out of 100 babies that were born into neonatal abstinence syndrome. The next year, 2015 to 2016, it went up to 32 per 100, and that's really easy to figure out percentages. And then 39 over 100. So almost 40% of our babies born into neonatal abstinence syndrome in those 2 years. Initially, we didn't really think that there was any after effects like we see with fetal alcohol spectrum disorder. But what we do see now is latency in language, and a lot of the children that were born, especially to higher use mothers, are having a lot of difficulty with language skills, so they're not speaking when they should, or they're not able to communicate verbally what they're feeling. So I've got like 4 and 5 year olds who are nonverbal, who have neonatal abstinence syndrome. There needs to be more research on what actually happens to the child, other than that they have a very high risk of becoming addicted as adults because they were born addicted as babies. Resiliency is a protective factor. Traditional teachings through elders, learning cultural traditions and language can restore resiliency in Indigenous youth. Cultural identity is a protective factor. This was a study that was done by Richard Oster and et al. And what they discovered is that the more people had knowledge of the language, the less risk they had of developing diabetes. So I think that learning and knowing more about your culture really helps with health. So one of the projects that I did was bringing the spirit home. It's a Kainai Safe Withdrawal Management Site, or detox. And as I said earlier, detox is on our continuum of care circle. And the federal government does not pay for detox on reserve, and the provincial government does not have the mandate to fund detox on reserve. It's not within either one of their mandates, and so it took a lot of work. And so at the end of the NDP's the NDP government, Sarah Hoffman was very good about talking to me, the health minister at the time, and saying, what can we do? And I said, there's a jurisdictional boundary which we cannot get past. Can you take a risk on helping us start our first detox? So Sarah Hoffman provided us with $2 million to build or to start a detox program on reserve. And that detox program, what it does is we take people directly to detox instead of taking them to the hospital, dumping them at the hospital, and then they're okay. Once the overdose is over, they get discharged. And sometimes you see the same patient back 3 times. So the detox would take in these patients, do a medical detox with them, and then work on getting them into treatment. So this was a very important program that we developed and still exists. And we probably need to look at doing this across the province, possibly across the country, in terms of finding a safe place for people to withdraw and find services elsewhere. We did try a safe consumption site on reserve. So at the height of the overdoses, Alberta Health Services provided us with a safe consumption site. But as you can see, this is the health center that I work at. The trailer is right in front of the health center, and on the other side of it is a parking lot where everybody parks to come to the health center. And so the shame of using this and having the community see them use it stopped them from using it. So we only had like 2 people use our safe consumption site within a 3-month period. So it got taken away. Okay, so naloxone, it's now in the nasal form. So we're looking at teaching people, and it's a whole lot easier than fumbling with needles and trying to save somebody's life. It's basically a nasal, it's like your nasal sprays, and is very effective. We've done a number of conferences. We've organized a number of conferences on reserve. One of the most memorable to me was a youth conference we did on reserve, where we had several artists come that did film, painting, poetry, writing, songs. They came together, and Gabor Mate and the Chief Roy Fox, attended this youth conference. And this time it wasn't up to the adults to speak, because youth are very, very shy to be up here on the podium. So how they spoke to us was through their art. So they did film, they did poetry, they did music, and they presented it to people. And what we did was, just like you are here, we invited teachers, health workers, childcare workers, and people who were involved in the development of youth. And we didn't allow them to sit at the same table as any of their colleagues. They had to sit with somebody they didn't know, so that the exchange would take place in terms of, how do we work across these silos of our own, where we work. But anyway, this was a really great conference. Adults listened to the youth. We heard from them through their art. And Gabor Mate, of course, was there, and Chief Fox, and Wendy English, who's from Begunny, was very happy to be sandwiched between the 2 of them.
A slow one. So this was a case of metaphorical intercultural collaboration, and I really appreciate the openness and the spirit of working together that we've had here.
So yeah, so I just wanted to end with it takes a community, you know, whether that be a local community or a larger community. It takes a community to address the situations that we're in and an understanding. So I really thank Pat for reaching out and people for reaching out to have me come today, because the key to addressing these problems is understanding where they come from and what we can do and where we can make the influence. So the last thing I want to say is because this is global, it's not just Blood Reserve, it's everybody in the country, that we really have to think solidly on policy and drug policy across the country, and how we can save lives and how we can help people to heal. Thank you very much.